Hello, I'm Bob Challoner, the President and CEO of Southampton Hospital, and I'd like to welcome you to another edition of Focus on Southampton Hospital, your monthly program about the goings-on at your community hospital. And today I'd like to welcome Dr. Elaine Karis. Dr. Karis, relatively new member of our medical staff and a rheumatologist, a specialty that we don't hear about quite as often. But a very, very important specialty, and one of very few rheumatologists on the East End, actually. So welcome, Dr. Karis, to the program today. And first of all, I'd like to just talk to you a little bit about yourself. Tell me about your training and how'd you end up out here on the East End?
So I began my medical school training at the State University at Buffalo.
Right.
I then returned home to New York City to do my specialty in internal medicine at Beth Israel Medical Center. I then did research for a year in lupus at the Feinstein Institute in North Shore Medical Center.
Okay.
I completed my training in rheumatology with a fellowship at New York University Hospital for Joint Diseases.
Wow, that's certainly an impressive CV. And how many years did all that take you just to finish all that training?
I would say approximately 10 years.
Wow, wow.
And after meeting you and Dr. Weinbaum and coming out here and your interest in having a rheumatologist, I thought this would be a great place to build a practice and raise my daughter, Gabriella.
Wow, great. How's she liking it out here? How's Gabriella doing out here?
She loves it.
Yeah.
What a better place to grow up.
Yeah, what a beautiful place to be. Absolutely right. Well, we are absolutely thrilled that you came, and I know that I've met many of your patients in the community already and are also very, very happy that you're here. So let's talk a little bit about rheumatology, first of all. Specialty that I've myself have sometimes early on wondered, what's rheumatology exactly, and what is rheumatology? What is the specialty focused on?
Rheumatologists are medical doctors, of course, who specialize in the care of people afflicted by skeletal problems, specifically joint diseases like osteoarthritis, rheumatoid arthritis, psoriatic arthritis, and gout. We also care for patients with autoimmune diseases, specifically lupus and vasculitis, to name a few. And we are specialists of bone disorders, most often osteoporosis.
Okay, so let's talk a little bit about arthritis initially. Arthritis is, we hear it all the time, oh, I think I have a little arthritis. What exactly is arthritis?
Well, Bob, arthritis is pain, swelling, inflammation, and stiffness of a joint.
So it's the inflammation of the joint itself, and there's several different forms of arthritis, aren't there?
There are a variety of different forms of arthritis. Most notably, of course, is osteoarthritis, rheumatoid arthritis, and gout,
okay,
as well as the autoimmune diseases, which frequently involve the joints.
Okay. Osteoarthritis is what?
Osteoarthritis is a localized problem with the joint, most typically occurring in the joints of the lower extremities, specifically the knees and hips.
And rheumatoid arthritis?
Rheumatoid arthritis is a systemic disease that can occur at any age, even in young adults, and typically is symmetric, affects the hands, the feet, the elbows, but can affect any joint in the body.
Typically, if you see symptoms, lower body, upper body, is that a fairly good tip-off typically if it's one or the other, or could it?
That could be one tip-off.
Okay.
The other tip-off would be the number of joints involved,
Okay.
as well as other things. Rheumatoid arthritis, since it's a systemic disease, can also be associated with anemia, fatigue, weight loss.
Okay. And what are the symptoms other than fatigue and weight loss? Is it joint pain, joint swelling?
Rheumatoid arthritis typically is brought to our attention because one will come down with joint pain, swelling, inflammation, sometimes low-grade fevers, make it very difficult for them to get out of bed in the morning, make it very difficult for them to do their job and function, because they typically begin to have trouble moving their hands.
Okay. And what's causing the pain exactly?
Well, the pain in rheumatoid arthritis is due to inflammation. which is different than osteoarthritis, which is more due to mechanical stress.
Okay, and describe that. What is the mechanical stress exactly? What do you mean by that?
So the more we learn about osteoarthritis, the more we realize its association with weight.
Okay.
So if one does suffer from osteoarthritis, we frequently advise them, first off, to lose weight, as weight loss is an important thing for them to do to feel better, as well as physical therapy to strengthen the muscles around those joints.
Okay. Is the weight because it's putting extra strain on the joint, or why is it linked to weight?
Well, we think it's twofold. One, we think it is due to the weight, due to the stress on the joints, but we also know that fat cells promote inflammation.
Oh, really?
In the joints.
Okay. So it's really a combination of things that are doing it. And when someone comes to you, they say, I've got pain in my joint, what do you do to try and identify if it is in fact arthritis, and then which type of arthritis?
Well, typically I would start with a physical exam and a history to find out when they're having the pain, if it comes and goes, if it's always there. And then if the joint is full of fluid, I will sample the fluid and send it to be analyzed, which is very helpful, especially to differentiate a mildly inflammatory form of arthritis like osteoarthritis from a much more inflammatory type of arthritis like rheumatoid arthritis or gout.
Okay. Gout, I've heard the term gout. I have a vague notion of what it is, but what exactly is gout?
Well, gout is actually the most inflammatory arthritis.
Okay. I didn't realize it was a form of arthritis, gout. Interesting.
Yeah. And it's a very inflammatory one. It's extremely painful.
Okay.
It can occur for the first time in the great toe, your first toe, and in other instances in the knee or the hand.
Okay.
The chances of getting gout increase as one ages, is more commonly in men, but can occur in women as they get older. It is associated with some other conditions like kidney disease, high blood pressure, and diabetes.
Okay. Is there any truth that it's related to diet, gout?
Gout is, out of all the arthritides, gout is the most related to diet.
Okay.
And we frequently and always actually advise our patients to follow a low purine diet.
What's a purine?
So a purine is an amino acid, and low purine diets actually are diets that are low. We ask them to limit mainly shellfish, red meat, pork, alcohol, specifically beer, and we ask them to stay very well hydrated because dehydration can precipitate attacks of gout.
Interesting. The lack of shellfish must be a challenge out here in the East End, actually.
It sure is.
Do you see more of it, do you think, because there's so much shellfish that's in the diet out here?
I think gout is very common, so it would be difficult to tell if I saw more or less of it, but I definitely have the challenge of high shellfish diet out here on the East End.
Interesting.
Yeah.
So, are there tests specifically that somebody you can definitively say it's this type of arthritis or that type of arthritis?
For sometimes.
Okay.
The answer to that is not always. So, with the physical exam and the other, diagnostic modalities, we try to put everything together to come to a conclusion about what's going on. So, I may sample the fluid. That can be helpful, at least differentiating a non-inflammatory from an inflammatory cause. In gout or pseudo-gout, we can look for crystals, which would make a definitive diagnosis.
Okay.
Then blood work is going to be important because if we suspect in a systemic disease like rheumatoid arthritis, we look for things like anemia and inflammation, as well as there are some blood tests that we can send specifically for rheumatoid arthritis, although those are not always positive in the disease. Mm-hmm. And x-rays actually can be very helpful, and most of my patients will get x-rays of their hands, feet, and other joints that are affected because it will show a pattern of joint destruction and joint damage, which can help to differentiate the diseases from one another.
Are there risk factors for the different types of arthritis, genetic or otherwise?
Most arthritis is genetic.
Right.
There are other components, of course, like diet, which can contribute, and environmental factors.
Okay. So clearly, you may have a genetic predisposition, but if you keep your weight down, probably less likely for osteoarthritis, for example?
Sure, and if your diet's appropriate, you may not develop gout.
Okay.
And in rheumatoid arthritis, we don't really know what the trigger is yet, but potentially it's going to be an infection or some kind of environmental trigger.
I've heard the discussion about autoimmune disease. Can you just explain that? What do we mean by autoimmune disease? And rheumatoid arthritis is an autoimmune disease.
It is, and autoimmune diseases are diseases in which the immune system will become disorderly and start to identify oneself as foreign.
Oh.
And for example, in lupus, one will form antibodies actually in some patients to their own DNA.
Their own DNA?
Their
so
own
the body is literally attacking itself?
Yes.
Interesting. Lupus, signs and symptoms of lupus.
So lupus is a disease that typically affects women of childbearing age and is associated in most cases with a variety of symptoms, which include fever, joint pains, sun-sensitive rashes, kidney disease, fluid around the heart and lungs, as well as some other symptoms.
I've heard the link between psoriasis and some forms of arthritis. Is that an issue?
That is. Psoriasis is probably one of the most genetically linked forms of arthritis, psoriatic arthritis. People with psoriatic arthritis may not even have psoriasis themselves. They may have a first-degree family member, mother, father, sister, brother, children, which have psoriasis, and it doesn't have to be severe for them to develop psoriatic arthritis.
Okay, so it's all essentially the immune system then attacking the body and creating these symptoms. Now, if somebody starts to develop symptoms, at what point, lots of us wake up some mornings with a little bit of joint pain or exercise and we're achy. When would you recommend that somebody actually start to think, hey, maybe I've got something else going on here, and go see a doctor, rheumatologist about it?
Most often anything that lasts more than 6 weeks. So if someone develops an arthritis, morning stiffness, other symptoms that may clue them in that something is wrong, sometimes it's fever, sometimes it's weight loss, they should probably be seen by a rheumatologist, definitely at least by their primary care doctor who can refer them to a rheumatologist to try to establish what is wrong. Also, I do think everyone with gout at some point should be seen by a rheumatologist, because as we learn more about gout, we're learning that it is not only an episodic arthritis, but that uric acid, which is the entity that is high in gout, and may also have other implications on your health. Okay.
Is it true with arthritis, as it is with some diseases, that the sooner you start treatment, the more likely you are to stop it from progressing? Is that the case with various forms of arthritis?
That is very true for rheumatoid arthritis, which is an autoimmune disease that specifically targets the joints and destroys and damages them rather rapidly.
Really?
So for those patients and those people, it is very important that they be treated very early on, and sometimes will require immunosuppressive therapies to prevent their long-term joint damage and disability.
That was going to be my next question. What do you do for somebody that's has the pain, and how do you treat it? And are the treatments different for the various forms of arthritis?
They're very different, actually. Some forms of arthritis, if limited, like gout or osteoarthritis, can do well with just a steroid injection into the joint to calm down the inflammation. Other times, non-steroidal anti-inflammatory drugs like ibuprofen or Motrin work very well to decrease that pain and inflammation, as well as physical therapy to strengthen the muscles around the joints. I may sometimes ask my patients to cut back on any activities that may be worsening their joint pain. specifically high impact activities like running.
Okay.
And I would encourage more low impact activities like swimming, walking, or biking.
Okay.
And I do always encourage stretching to everyone because it is important to keep the tissues in the joint and around the joint healthy.
Right.
And stretching improves blood flow and lymphatic drainage from the joints.
Stretching before or after exercise?
Both.
Both? Okay, all right.
Yeah. Stretching all the time.
Stretching all the time, okay, good. And repetitive motion kind of issues, can that trigger an arthritic issue as well?
I do see a lot of repetitive motion injuries, but those are mostly related to tendon injuries.
Okay.
So those people will get more tendinitis.
What about for rheumatoid arthritis? What are the treatment options for that?
So rheumatoid arthritis has come a long way in the last 20 years. Previously, it was a debilitating disease. But now with therapy, and we have a variety of therapies in our armamentarium, most of which are immunosuppressive therapies, which are safe and effective to both decrease the inflammation, pain, swelling, we try to remit the arthritis as best we can, and to allow those people to live a normal life. And our treatments also prevent any joint damage from occurring if treated, especially early on.
So the old image we have of the rheumatoid arthritic with the sort of neurally crippled hands, you can stop that progression at this point, or?
That rarely ever happens these days. If someone is brought to a rheumatologist and initiates treatment early on, the majority of that, if not all of it, can be prevented.
Okay. The immunosuppressive drugs sound scary to me. I've heard them in reference to cancer and other things. What exactly are those drugs doing from a layman's perspective?
Well, I think the longer that they're around, the more we realize that they actually are safe treatments. Their association with cancer is becoming less and less believable these days, the more we learn about them, and the more that research is done. It seems that the diseases themselves actually increase the chances of cancer more than the treatment.
Oh, really?
And actually that the treatment will help to prevent the possibility in some instances for the development of cancer. And of course, immunosuppressive therapies do increase the risk of infections, but since we know as much as we do these days about the infections, we screen people ahead of time and we know how to monitor them, and it rarely ever becomes a problem. And of course, we don't use immunosuppressive doses like they do in cancer treatment. We use much smaller doses.
And is it a drug that people need to take essentially for the rest of their lives if they?
Sure. In rheumatoid arthritis, the majority of people will need to be treated lifelong.
Lifelong, okay. But I guess that's the key, to stop it before it does start doing all that damage to your body. Other non-drug treatments, and it sounds like with rheumatoid you obviously need but are there other things you could be doing as well? You mentioned physical therapy, hot and cold therapies at all, does that matter? Or heat, warm packs, anything like that, would that help?
Well, for my acutely inflamed joints, I would recommend that my patients use ice. Specifically with osteoarthritis and gout, ice seems to be very effective. But for rheumatoid arthritis, they tend to find warmth much more soothing.
Okay.
And as we discussed earlier, with osteoarthritis, weight loss is going to be of utmost importance. Sometimes it's just a matter of 5 or 10 pounds. And in other situations, we might actually recommend bariatric surgery.
Okay. So the exercise, I always wonder about exercise. I wonder how you deal with telling somebody, you can't exercise anymore. And other times I hear the best thing for joint pain ultimately is to get up and moving. What's the real story? Isn't it a catch-22 to, the whole exercise versus arthritic issue?
Well, I rarely ever tell my patients they can't exercise. I might have them limit certain kinds of activities temporarily, but my ultimate goal is for them to resume their usual activities.
Okay.
Of course, as we discussed, swimming is the has practically no impact. So that's always going to be okay to go swimming if your joints hurt. But other activities we may like to limit, like running and heavy weightlifting.
Okay. Does walking help at all, or just continuing to move? Is there, I guess the question I would ask, if you're not exercising, you become very sedentary because it's painful. Does that make it worse?
Usually it will.
Okay.
It is really important for people to keep moving, and it's good for your joints despite the pain that one may feel. Movement is going to be a very important part of recovery. So when a joint is stiff, movement will make that joint less stiff, over time. Stretching, strengthening exercises, these are all going to be important for the joint. So I rarely ever tell people to limit their activity.
And I know that an option for some people when the joint becomes very diseased is joint replacement surgery. At what point should people basically say, okay, it's time to get surgery?
So that decision is made on a case-by-case basis and taking into account pain and disability. Mm-hmm. And if someone has a great deal of pain, not controlled on Tylenol or Motrin, non-steroidals, who's gone through physical therapy and really isn't getting better, mm-hmm. We may elect to do joint replacement.
Okay. And what's the success rate with joint replacement surgery?
The success rate is great, especially for knees and hips, and as well as shoulders. And it is very important, though, to participate in the rehabilitation post-operatively for best results.
Okay, which can be a lot of work, but ultimately is the way to go, I've heard.
It's the key.
An old school time thing, kids that used to crack their knuckles, I never could. I was always jealous of my friends that could crack their knuckles, but then I've always heard it said that that'll cause arthritis. Is that true, or is there a linkage with cracking your knuckles and joints and arthritis?
It doesn't cause arthritis, but I think most people would prefer if you didn't crack your knuckles.
I agree. It's kind of obnoxious people that sit there and do that all the time, but it's not a cause for arthritis.
Nope.
Okay. So one of the things that's particularly concerning for people out here in the East End is Lyme disease and tick-borne diseases, and I know that you're on our tick-borne panel of experts, and we very much appreciate your being involved with it because it does. One of the consequences of all of these tick-borne diseases does seem to be joint pain. And what exactly is going on with Lyme disease in the joints? What are the long-term consequences for the joints as a result of Lyme disease?
Well, Lyme arthritis is a very common thing to occur following Lyme infection, especially if it's not treated right away. One can develop arthritis. It's usually in one joint, typically the knee, with a great deal of swelling. If we can get a sample of fluid, we can look for the bacteria in the fluid, which would help to diagnose that as being Lyme arthritis. Also, probably about 100% of people with Lyme arthritis would have a positive blood test for Lyme, again, making it easy to make that diagnosis. And the majority, if not all patients, should respond to doxycycline. Occasionally, they require a second course.
Okay.
Now, since the immune system, of course, becomes involved in any infectious problem, in some cases, like any other infection, the immune system can be triggered and lead to a long-term arthritis.
Oh, similar to an psoriatic arthritis, or is it a?
Sure, it's. I would say it's most similar to that. Yes.
Okay.
But it's not anymore due to the active infection. It's due to the dysregulation of the immune system.
It's the body. The infection's gone, but the body at that point is attacking it.
Causing the problem.
Okay. How frequently are you seeing Lyme disease out here at this point, or Lyme-like arthritis, or Lyme-caused arthritic symptoms?
Surprisingly, not very often.
Okay. And so that is surprising given the number of ticks that we see, and certainly the fear that we have about tick-borne diseases. Are there any other than Lyme disease? I know that ticks are creating or causing a number of different diseases. Are there any other any other illnesses that trigger arthritic symptoms also?
Well, it could be any infection. Tick-borne infections are usually Lyme that
Okay.
triggers joint disease, but there are a variety of other infections that are not tick-borne that could trigger arthritis as well. One of which is parvovirus, which is seen in children, and we have seen out here.
Okay.
Lyme arthritis itself may be less prevalent than thought, possibly because the primary care doctors out here are so good at detecting and treating early on.
Okay.
So it doesn't really become a problem for a lot of people.
Just because somebody's been bitten by a tick or may have had Lyme disease doesn't mean that they will necessarily get arthritis long term?
No.
Okay.
They probably won't get arthritis long term,
Okay.
especially if they haven't developed the initial arthritis that occurs from Lyme infection.
Okay, well that's good to hear, because I have heard some people say I was bitten by a tick, now I'm going to end up with arthritis, so not the case probably. So I want to talk a little bit more about psoriatic arthritis, and we've all seen the television commercials from pro golfer Phil Mickelson. I always thought of psoriasis as a skin disease. I'm surprised that it's actually linked to arthritis somehow. You said it's an autoimmune disease also?
Well, it's more of a genetically linked inflammatory disease, I would say.
Okay.
I don't know if I would label it as an autoimmune disease, because we tend to think of autoimmune diseases as associated with autoantibodies,
Okay.
whereas psoriatic arthritis is not. But it is a dysregulation of the immune system, probably mostly genetic, probably with an environmental cause. And it is inflammatory and may not always have psoriasis apparent at the time that the arthritis develops.
Okay.
But it's also treated with similar medications to rheumatoid arthritis.
So the autoimmune drugs, they're not autoimmune. The immune therapy drugs are the same kind of things that you would use for it?
For rheumatoid arthritis, they're very effective.
Okay. And one of the supplements we hear for treatment of arthritis these days, glucosamine chondroitin. How effective is that? Is that something that really will make a difference?
Well, I would say the verdict's not out on that completely. I do not discourage my patients from taking it if that's something they're on or something they would like to try, but I don't require that they take it.
Okay. Is it really ground up shells from crabs and things, or lobsters, or?
I believe some of the components, maybe.
Okay, interesting. So what are things that someone can do to prevent arthritis if they have a family history of it, or maybe they've started to see a few signs of it? Are there things we can do to really prevent or at least postpone the onset of arthritis?
Well, not everyone can prevent their arthritis from occurring, but in some instances like gout or osteoarthritis, there are things one can do, including following a low purine diet, as in gout, making sure that they're exercising regularly so they do not become overweight or obese.
Okay.
But other than that, I would say we don't really have too many other preventative measures that we recommend.
Smoking is a factor for a lot of diseases. Is it with arthritis at all?
It is a risk
Okay.
factor for rheumatoid arthritis.
It is, okay. So lots of reasons to quit smoking, and that's one of them. And we just have a couple of seconds left, but just anything new in the research world in arthritis? Any hope on the horizon, I guess?
Sure. Rheumatology's come a long way in 20 years,
Right.
and there are many dedicated medical researchers as well as pharmaceutical companies that are always looking to advance the treatment of our diseases and looking for more safe and effective treatments all the time.
Great, wonderful. Well, Dr. Karis, it's been a pleasure talking with you today, and we're very lucky to have you here in the community. I'm very happy your daughter's happy, and I know you're busy, but if anybody would like to make an appointment with you, I know that the number is 631-594-3910. And Dr. Karis is seeing patients at our Meeting House Lane offices at the Atrium in Hampton Bays and in Southampton. You're splitting your time, I guess, between both locations. So.
Actually, right now I'm full-time in Hampton Bays.
Oh, you are? Okay. Okay, great. Well, thank you very, very much for being with us and all the great work you're doing in our community.
Well, thanks for having me.
And I'd like to thank all of you for watching today. And once again, if you have any questions or concerns, would like to learn more about arthritis, or need help navigating our healthcare system out here in the East End of Long Island, please call my office at 631-726-8555. Also, I'd like to thank our friends at CTV for producing and airing the show in Southampton, and our friends at LTV for airing the show in East Hampton. I hope you all have a wonderful holiday season and good health, everyone. Thank you.